There is a jar on the kitchen counter, white cream, a pharmacy label, a strength written by hand, 10% ketamine, beside it a bottle of troches that dissolve under the tongue, and in the folder from the clinic, a printout of a study, an infusion study. Nobody in that room has told this patient that the paper on the counter and the jar on the counter have nothing to do with each other. I am Dr. Padda, and I want to be precise about this. And I practice interventional pain management in St. Louis with a second location in Bridgeton. The person holding that jar has a limb that has burned since an injury that healed a complex regional pain syndrome, what older charts and most of my patients still call reflex sympathetic dystrophy, or RSD. They have already been failed once by the year it took to name it. I want to talk about the second failure. Ketamine is not one treatment. It is 3 treatments that share a molecule, and the evidence does not transfer between them. A patient is handed a jar and a bottle, then quoted an intravenous trial, or booked for a 40-minute infusion and told that produced 11 weeks. It was not. So I am going to say on camera which of the 3 routes has controlled evidence behind it, which has exactly 1 day of it, and which has none. The reason anyone reaches for an NMDA antagonist in a limb like this starts in a rat's spinal cord, and you are entitled to know that before you consent to it. In animals, investigators record from dorsal horn neurons, deliver repetitive nociceptive input at one fixed intensity, and the output climbs. Glutamate accumulates, the magnesium ion plugging the NMDA channel is expelled, calcium floods in, and system gain rises. That is wind up, measured with an electrode in a laboratory animal. None of it has been measured in your body. We infer it because your allodynia has outlasted the injury by months and spread beyond a single nerve territory. That is a reasonable inference, not a recording. And anyone who talks about your spinal cord as though he had an electrode is guessing. Ketamine is a non-competitive antagonist at that receptor. That is the entire rationale, and rational is not the same as proven. One precondition before any route. This diagnosis is made with the Budapest criteria, and by exclusion, deep vein thrombosis, cellulitis, occult fracture, radiculopathy, entrapment, small fiber neuropathy all imitate it, and diagnostic sympathetic blockade answers whether the sympathetic system is participating. I have walked through that workup elsewhere on this channel. If the name has not been earned that way, nothing that follows is a treatment decision. It is a guess with a controlled substance attached. So take the 3 routes in the order the evidence ranks them, which is not the order a clinic finds convenient. Intravenous is where the controlled data live. Sigdermans and colleagues in Pain in 2009 randomized 60 patients with complex regional pain syndrome type 1, median duration over 7 years, to a 100-hour continuous inpatient infusion of titrated S-ketamine or placebo. Week 1, 2.7 out of 10 on ketamine, 5.5 on placebo. That separation held through week 11 and was lost at week 12. Now the 2 sentences clinics leave out. Treatment did not cause functional improvement, pain fell, function did not follow, and psychomimetic effects occurred in 76% of ketamine patients against 18% on placebo. 3 of 4 felt dissociated. That is the study. 100 hours inpatient S-ketamine monitored. Nothing shorter has earned that result. Topical is a separate literature. Finch, Knudsen, and Drummond, also in Pain, in 2009, ran a double-blind, placebo-controlled crossover trial of 10% ketamine cream in 20 patients. It reduced allodynia to light brushing and hyperalgesia to punctate stimulation, with plasma ketamine undetectable an hour later, local, not systemic. But normal touch thresholds did not change, and durability was never measured. That trial tells you about the same day and nothing about the same month. Sublingual ketamine has no controlled efficacy evidence in this condition. When I use it, I am acting on practice preference, not on a trial, and you are entitled to know that before it is dispensed. One boundary, because the title of this video is broader than the evidence in it. If what you have is refractory neuropathic pain without complex regional pain syndrome, post-herpetic neuralgia, a painful diabetic neuropathy, a nerve injured in surgery, I understand that every number I have given you was measured in complex regional pain syndrome. The mechanistic rationale carries over. The 11 weeks does not. Anyone who quotes you That figure for a different diagnosis is quoting a study that did not enroll you. Ketamine is approved as an anesthetic. Every use I have described is off-label. Compounded creams and troches are not FDA evaluated for potency, sterility, or effectiveness, and strength varies by batch. And be precise about one word. The trial drug was S-ketamine, that is S-ketamine, the same molecule as the nasal spray approved for treatment-resistant depression. Same molecule, different product, different route, different indication. That approval says nothing about your limb, and nothing that happens in this office is that product. Ketamine is Schedule 3 with real misuse and dependence risk. Beyond dissociation, expect sedation, dizziness, nausea, blurred vision, and a rise in blood pressure and heart rate, which is exactly why the cardiac screen is not a formality. If troches go home with you, the quantity is limited and governed by a written treatment agreement, because a Schedule 3 drug sitting in a kitchen drawer is a diversion risk whether or not anyone in your house intends one. And the cream transfers by touch. Wash your hands after every application. Keep the treated skin covered, and keep the jar away from children and pets. A dose that is therapeutic on your forearm is not a dose anyone else should receive. Repeated or high-dose exposure carries ulcerative cystitis, sometimes severe and not always reversible, plus liver injury, so we monitor urinary symptoms and enzymes. Infusions require continuous vital sign monitoring, resuscitation equipment, and an adult driver. No driving and no legal or financial decisions on a dosing day. I will not treat you if you have uncontrolled hypertension, unstable coronary or cerebrovascular disease, raised intracranial or intraocular pressure, active psychosis, significant liver disease, or active substance use disorder, or if you are pregnant or breastfeeding. The 2018 consensus guidance from the American Society of Regional Anesthesia and Pain Medicine, with 2 partner societies, is explicit. Benefit varies by condition and dose. Most supporting studies are small and methodologically limited, and its monitoring standards cover intravenous use only. Every trial here carries a stop date from day 1. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. A limb injured, immobilized, healed on imaging, then a year of burning that nothing could touch. Sympathetic blocks that helped for hours. A membrane stabilizer at a dose that made thinking difficult. A therapist who could not begin because contact was unbearable. We began where risk was lowest. Compounded 10% cream to the allodinic skin with the understanding, spoken and written, that its evidence covers a single day, not a season. It made a bedsheet tolerable. That is not a cure, and I did not call it one. But it bought enough contact tolerance for the therapist to begin. I am not going to tell you the therapy restored that limb. The one controlled infusion trial in this condition lowered pain and did not move function at all, and I have no trial that says desensitization would have. What I can tell you is narrower, and it is true. A limb no one can touch cannot be worked on. This one could be touched. A monitored infusion came later, after cardiac, liver, psychiatric, and substance use screening, with a driver and a stop date set before the first drop ran, and with the same sentence said out loud again, in the consent, in writing. What we can deliver in an outpatient bay is not the 100-hour inpatient study. It is an extrapolation from it. It was offered as a time-limited trial and recorded that way, and if it had not worked, it would have stopped on the date we had already agreed on. What took time was the therapy, not the drug. What was hard was the honesty. If burning, swelling, and temperature change have outlasted the injury that caused them, get the diagnosis named first, then ask which route the evidence supports. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Ask for the evidence by route. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.